Welcome to Listening First, the podcast on rehabilitation and recovery. I'm Patrick Boyd.
And I'm Ben Merrim. And we're back, Patrick. We're finally back. I feel like this is the thing, the gateway we needed to pass as podcast hosts.
Boys are back in town. Yeah, we are fully back. Yeah, it's been a long time, Ben. It feels like a long time anyway. In the grand scheme of things, it's been a couple of months, but I've missed you and I've missed this.
I know. We actually joked before we start recording this that it feels like it's taken us a little bit of a while to sort of get back into it, and I was hoping that sort of getting back on the bike, getting back on the horse, it would feel fine. It feels all right, Patrick, doesn't it?
It feels all right, yeah. I've been really excited about getting back actually and recording, and I'd probably underestimated just how much time it takes to plan and then record and then edit and get them out to everyone. And as with all of us who are busy working professionals, sometimes you get to a point where your workload just has to take priority, and that's kind of what's happened for me recently, but things have settled down a bit more now, so I've got a bit more time to give to the podcast.
Yeah, no, I guess we did record this quite a lot of weeks ago now, and it was good coming back to the episode and re-listening to it. Partly, I think, to almost experience it as a listener first time, like what the kind of conversation was like. And if anything, it's kind of spurred me on to properly focus on this again, Patrick, because it was a really good conversation, I think.
It was. Even though we had the conversation a while ago, things that have been happening in my professional life recently have really brought the conversation into focus. So some of the things I've been doing recently has caused me to revisit some of the social work theory that is so integral to our training as social workers. And it's caused me to think about how we work with not just the people who are going through rehabilitation, but their families and the people around them. It really made me think about things like Bronfenbrenner's eco maps and you know, thinking about the person within the system that there exists, not just the person, but their family and their friends and their home, their education, their work, and how all of those things interact and have an impact ultimately on the person at the centre. And I think this conversation that we had with this guest really focuses on not just the person at the centre, but everything that kind of exists around them.
Yeah, I totally agree. And I think particularly in listening to this conversation and understanding this person's role within particularly our context, which is that kind of more medical legal landscape, it was really exciting to hear about that type of role in this type of work as well. So that probably makes sense that we introduce the person now. So we're speaking to a family therapist called Dave Kenny, who thankfully gave his time to speak to us.
Dave, welcome to the podcast.
Yeah, thank you very much. So I'm Dave Kenny, and so I'm a qualified family therapist and an approved supervisor as well. And I live up in the northwest of England, so a place close to Southport. But I work all over the region, so Manchester, and Cheshire, Wirral and Lancashire as well. And at the minute, I work exclusively with families where there is a brain injury, and the families are often in litigation or it is post-settlement. So personally, I always think it's a nice idea that we humanise ourselves. So when people meet each other, we get to know that actually they're a family member, and I'm a son, I'm a husband, I'm a brother, and I'm a dad to a little boy as well, who's only 22 months old. And I'd like to take a moment just to immortalise my dog, who's called Ralph. So sadly, he passed away only a couple of days ago, but he's been a huge part of family life for over a decade as well. So I went from being a dog owner and an avid dog walker to missing him at the minute. So I did want to kind of do a little bit of shout out to Ralph, our beloved dog. And yeah, I consider myself to be very kind of family orientated, and we go out on lots of walks. I'm a bit of a football fan. Unfortunately, I support Everton, which is just a terrible team to support if you want to try and enjoy football. And I love the job that I do as well. I'm really excited and happy to be here today for this conversation.
Well, thanks so much for joining us, Dave. It's really good to hear a little bit more about you, and I am sorry to hear that you're an Everton fan, but you know, But, someone has to support them, don't they? As a
Yeah.
Newcastle fan, I'm not much better, to be honest with you. I have my fair share of heartache with following that club.
Yeah.
But, and thank you for joining us as well in the wake of the loss of your family pet. But I think I'm really glad you've mentioned it, Dave, because I think so much of the work that we do with people going through recovery and rehabilitation is about dealing with loss and change and
Yeah.
grief, and it's a human response, isn't it, to experience those kinds of emotions. And I suppose for our clients to know that we as the professionals feel exactly those same emotions is really important, isn't it?
Well, it is, because I think it's given the family, it's a period of reflection about losing something that was so important. And I can come into this kind of later on as well, but how it's kind of like how lifestyle changes when there's something like this occurs, how the structure of the family changes, how duties, responsibilities kind of go, you're kind of a bit lost, kind of what do we do and who's going to do it. I'm not comparing the loss of a dog to kind of a major trauma and TBI in any way. I think that would be probably unhelpful, but definitely as a family, we're feeling the effects of this loss. And which I'll come to and hopefully we talk about, is the ripple effects of these things upon families that we work with.
Yeah, and I'm really sorry to hear about the passing of Ralph as well, and it made me reflect that often, and maybe we'll get into this too, that I think when we talk about family, we think of it in what a nuclear family is, so that kind of genetic, like brothers, sisters, mother, father. But obviously, I think as a psychologist, family is much more subjective and about who's meaningful to us, and that includes pets or friends or people who've been, had an important part of our life, who formed the narrative of our life. But we're already getting into it. I think I'm just really curious about probably how you got into family therapy, how you train as a family therapist, what is family therapy? There's a whole ton of questions there. So maybe we kind of start with how you got into it and what it is.
Yeah. So I'd say the world of family therapy found me as much as I found family therapy. So thinking back, you give your age away, don't you, when you kind of start to give dates and time frames and stuff like that. But I think I've been in the career of kind of working with people a good 25 years now, something like that, I think it is. And I was always kind of being in school. So I went to an all boys school, and I was always really interested in the kind of lads who were seen as naughty. So these are the lads that the teacher would tell off. Like if I got told off, I'd go bright red and I'd just go, okay, yes sir, no sir, whatever, and just comply. And I was really interested in the lads who didn't, and they would stand up for themselves or they would storm out. I was really interested in what's going on for them. And so I kind of got into, as an early age, a bit of mentoring. So I was, say, 15, and I'd go down to the lower school at the lower site and help out like a 12-year-old who was maybe struggling for different reasons. So it was probably my first step into the helping profession, so to speak. So I chose psychology at university. Didn't kind of feel like I was ever really directed in, this is what clinical psychology is, or this is what, maybe if you wanted to kind of, have a career in psychology, this is what to do. So I came out of university a little bit at a loss. Went back home and found a job. This is the kind of luck along the way, really, is it? So I found a job in what was a treatment foster care team, where my role was to be a mental health worker with kids who were in care. But that role was working with the kids, working with the foster parents, and working with the biological family. So I was very green, very new to all of this. But looking back, I had brilliant supervisors. So I had a Gestalt therapist. I had a family therapist who was running the service as well. So he trained in the States as a family therapist, which is slightly different training. I had social workers supervising me. I had psychologists supervising me. So this is, 20, 21 years of age. So I stayed in that role for quite a while, really. And I wondered if I started to get kind of itchy feet, wanting to maybe progress my learning, my understanding of what's happening, and kind of leadership, really, I guess. I kind of wanted to be in it. Leadership's probably the wrong word. Being able to kind of help others develop their practice as well. So I didn't know really what to do. And I stumbled across the foundation level of family therapy in Leeds, and I was supported to do it. With time, some funding towards it as well. The minute I stepped into that learning context, I could almost connect everything I had been doing, all my supervision and working systemically in this service with kids in care, was what then I was being taught. So I started to learn the theories. I started to learn much more the language set, thinking about a kind of how families transition and the structure of families, and more about attachment emotions and things like that. So as soon as I stepped into foundation level family therapy, I just did the whole 4 years and came out as a qualified family therapist. Then I moved to a CAMS team, so it was an outpatient CAMS team, and worked as a case manager, family therapist there as well. So I'm not sure whether at this point that kind of brings me up to being a family therapist. And then I don't know whether you'd like me to share a bit more about how I got specifically into working with brain injury. So what do you two think? Or is there any more questions about my journey up to that point?
Yeah, I think before we go into talking about what you do now,
Yeah.
it would be really useful, Dave, if you would just help us to understand what family therapy actually is.
Okay. So there's a few assumptions, I guess, as a family therapist. And one of the assumptions is that, say, psychological distress or symptoms, say anxiety, things like self-harm, to a degree, something like, low mood, depression, psychosis, potentially. You could understand that, not exclusively, as being a response to what's happening in somebody's environment. And often what's in somebody's environment are people and family members, significant others, people in positions of authority. You can imagine how a pupil in a school may not respond that well to a certain teaching style, but responds better to a different teaching style. So our kind of foundational assumptions are that the immediate environment can emphasize or amplify somebody's psychological distress. Being a family therapist, we would focus much more on the relationships then. So we would be meeting the family and figuring out kind of how are you doing the relationships? What conversations do you have? What values do you as a family hold? And what impact is this having on psychological distress in the individual? I also think it's important to say that in no way do we deny that there are introspection and there are theories that we fundamentally agree with about the individual experience of the world and the environment as well. But your family therapist would very much convene the family around the client or with the client and try and work out how can what's going on in the family and in community. So we look through the different levels. How does the community affect the individual? How does the decisions made by the government affect the individual as well? So all these different layers, how they're influencing each other, that fundamentally then impacts on the client or the family. So we call it systemic. So all of those themes I've just mentioned is what we call systemic influences.
Yeah, and it got me thinking there, Dave. Systemic is the system, isn't it? And the system can be anything, including cultural issues, environment. I remember when I was trained to be a psychologist working in a children and young people service in Sunderland. And Sunderland is an area of real social deprivation and difficulty. And I think part of one of my frustrations trained as a psychologist was I'd often be asked to see a young person, but actually what was going on at home was the thing that was contributing so significantly to their distress. And I wondered about you, Patrick, as a social worker by background, often the problem is placed within an individual, isn't it? But often it's the environment around the individual that's contributing so significantly to that distress. And as you were talking there, Dave, that really joined those dots for me when we talk about system level stuff. Is that what, for you, Patrick, as a social worker, did you see a lot of that?
Yeah, absolutely. And I do as a case manager as well. I say quite often that working as a case manager, I feel like my day-to-day work's more closely aligned with the work of social work in the truest sense in terms of my training than when I worked in a local authority. We learn about things like family systems theory in social work and understanding the impact of the people around an individual, and like you say, Dave, the impact of an environment in itself. But then thinking now about my work with people with brain injuries, understanding the impact of that injury on the wider family and how they then support the person with the brain injury. Like just some stats that I picked up recently from a book by Joe Clark Wilson and Mark Holloway in their book on the impact of ABI on families. 67% of partners and families feel ill themselves after their family member sustains a brain injury. 90% feel under constant strain, 80% lose sleep, 25% feel like life's not worth living. So the impact of an injury on an individual doesn't just affect them, it affects everyone around them as well. And I guess that's from my perspective as a case manager, that's where family therapy comes in, because it isn't just about the individual, it's about the whole family system.
And Patrick, did you know if it wasn't for social workers, there probably wouldn't be family therapy? Did you know?
Really? Is that right?
Yeah. So it goes back in a little bit more history. Also in the States, really, the social workers were going in to really kind of help kids at the time who were maybe struggling, and all the social workers were kind of got together and said, surely we can do more. Surely if we help the system, we can help the child. Around the same time, you had some people in positions of power, like some kind of psychiatrists who were heading up institutions and medical centres, starting to notice the same, who could actually apply for grants to then do some like experiments. So these experiments, have you seen the Simpsons episode where like the doctor hooks them all up to electrodes and they all get shocked when there's a criticism? I don't do that. I don't turn up with some kind of electrode system or whatever it would be. But they did do a whole bunch of experiments. Were they ethical? I don't know. We're going back 60 years or so, whereby they were kind of really noticing much more positive outcomes for the individual if you worked with the entire system. And in the world of, say, psychosis and schizophrenia, when patients or clients were being discharged from an inpatient unit, but were coming back in after only kind of 3 to 4 months, all these institutions began to realise, actually, if we involve the family in understanding, in the care, in things like stress management, in more contemporary, I would say, getting them into dialogue and getting them into conversation, then there was less readmissions as well and less medication needed. So these clients and their families were just being helped as a whole. So the foundational work 60 years ago brings us to where we are today, really, which is family therapists now a bit more common in the NHS services and working independently now with families.
So just to summarise then, Dave, the aim of family therapy is to work with the full system around an individual to make sure that essentially everyone's on the same page, pulling in the same direction and doing what they can to make their whole experience better. Is that right?
Yeah, I think that's the ideal, Patrick. Yeah, if a whole family through the work of a family therapist feel that they're pulling together, brilliant. You often find actually that the fact that people are pulling in different directions is time is given to acknowledge that, to think about that, to build an awareness of that. Each different part of the system could have a really good rationale for pulling in a different direction as well. And often you might hear me say, if we ever work together or you work with a family therapist, having opposing views and perspectives coexist at the same time. So it's actually giving space for somebody wanting to pull that way. Another part of the system, and you're right to say system because this is also including professionals as well. Professionals have a huge impact on a family. It's not just family members or significant others. But I was saying another part of the system may want to pull in a different direction. So that could cause tension. And a family could feel in the middle of that tension. We call that triangulation. So the family feel, why is the deputy talking about this when the case manager is talking about that? And we don't know what to do. And the stress and tension being created, and now we're shouting at each other. Yeah. So systemically, you can see something is going on in the MDT. So that said, simply having conversations in which there is now an awareness that there are people are prioritizing or privileging different directions is sometimes enough to make that less of a problem, Patrick. But, but I would also agree fundamentally, if after a year or two, people feel like, do you know what, we went through the mill together, we were in such different positions, or there was like polarization of what we should do. And now by and large, we're pulling in the same direction and we can accept it when we're not, and we can talk about the differences. That's equally as good as an outcome.
Excellent. That's really useful. Thanks for that, Dave, because my experience is largely in working with adults and working with individuals who require care and support under the Care Act. So family therapy hasn't necessarily formed a huge part of my experience as a social worker as it might with somebody working with children and young people and families. So it's really interesting to hear that kind of background and how the profession in itself has come about. So could you explain to us how you've come to kind of do the work that you do now then?
Yeah. And I could I just reflect on something that you said a moment ago? Yeah. So sometimes I feel it's a real shame that a client could be, 17 and 160 odd days and get a whole raft of, and people would think of something like family therapy. And then only a few days later, the system may no longer think of family therapy because they are of a certain age, and then capacity questions come into it and all of that. And I suppose when I worked in adult-facing psychosis team, I was a big advocate for saying, let's maybe suspend that idea that this should only be available where there's a child or somebody, under 18 or under 16. And let's imagine this is almost like an opt-out kind of situation in which family therapy is more available for whoever, really. But I know we're not there yet in family work because this is me today's kind of introducing it to people as well. It may not always be that available for people. So yeah, so I kind of took us up to the point where I became a qualified family therapist. I was then supported to do the supervision course, which is about another 18 months really, and pretty hard work and, pretty full on. And I was running family therapy clinics. And then the opportunity came to step into more of a leadership in a psychosis team, which was to develop the systemic pathway. So I won't go too much into that, but that was around 6 years of kind of running that pathway. And it was actually, my wife is a psychologist doing her QICN to be a neuropsychologist. And she's brilliant at what she does. And she got the opportunity to work with Newby Psychological Services. So Newby Psychological Services operate up in the north of England as well. They operate everywhere, but predominantly in the north. And so that was working independently as an associate for Newby. And she mentioned me to them and said, my husband is a family therapist. Would you take a bit of a punt on a non-psychologist in your team? And they said yes. So I know other people like Vicky Gilman's kind of mentioned that tension between moving into independent practice, and it means different things to different people. And it was never my plan. But I think I got interested in the family being in a different system and under a different framework, litigation and post-settlement. And actually that's different pressures to families. And I think I got a real keen interest in maybe moving away from mental health and all this kind of systemic and the multi-levels and, what influences families that way, and a bit more into something that was quite unique for me. And I felt a bit of a novice again, but I felt it really helped my curiosity. It helped me try to understand a new framework in which families find themselves in, and the frustrations that can add and can bring to them. So here we are. I've probably been doing that. My first kind of step into working with Newby maybe 6 years ago. So I've been working with as ABI or TBI within litigation or beyond for about 6 years now. But I moved fully into independent practice 2.5 years ago now.
I think if I've got this right then, Dave, so if we think ultimately family or systemic therapy is about the sort of family in whatever way that's defined, being at the centre of thinking, and it's about how a system puts tension and pressure on them, is that Correct. A good way of summarising it?
Yeah, 100%.
So then,
yeah.
So my question emerges then as bluntly as it is to ask it, what do you do then? So what does, you mentioned a reflective process there, but what does a family therapy session or assessment look like? And we might move on to thinking about why it's relevant to brain injury recovery, but what do you do? What does a session look like? What is therapy?
That's a nice question, and I'll try and I use imagery a lot so people can imagine it. But I think the other thing to say is case managers and some psychologists, maybe less so, they're sometimes a little bit surprised that I would ask for, or in my assessment kind of assessment estimate, there's actually time to spend with the MDT. Because often people would say, this is the family, this is where they live, can you go and see them? And I'm like, yeah, but before we do that, I want to hear the referral story. What is it that the MDT are saying, and what's the narrative about this family? Where maybe are the challenges being identified by the MDT? Let me understand that first, and then I'll go and meet with the family and I'll hear their narrative. And then you will get kind of these two sides emerging, actually. So the assessment is based around about 4 sessions, depending on the size of the family. So aside from the meeting the members of the MDT and hearing from them first, or at some point in the assessment, my initial assessment with the family is the family as a whole. So the significant people you're right, Ben, in whatever way they define themselves. And that is a joining. I am joining them first, wherever they are, however they see the professional system. I'm going in very kind of like almost in a vulnerable state. I'm kind of like, I'm here to help you. You tell me how I can fit with you here. How can I align with you? What's your story? Do you even want me here? Who's encouraged family work? What do you think of that? So that's the first session, or the first assessment appointment with the family, is a joining. And it's a genuine, authentic joining. I'm not using any tricks. I kind of genuinely want this to go well. I want to hear from them about somebody from the professional system being asked to come and assess them, and what's that like, and all of that. So then I offer individual appointments in the assessment to try and keep them relatively short and in the same visits, to cut down on costs as well. So I could see up to maybe 3 members of the family on the same day, and that's hearing their individual perspectives. That's giving them a chance to speak openly without feeling that they may, if they're worried about criticising their loved one, they don't have to worry about that. They can speak to me openly and honestly. And then I'm kind of tracking how family life has changed because of the ABI or TBI. But I'm also keeping an eye out and an ear out for the value system and how the family was structured before the index event, what was important to them then, and how has that changed now, and what enforced changes are we seeing as well. I'm also listening out for things like conflict, intimacy, if it's a couple relationship, changes in how they parent, if it's a parenting subsystem, so to speak. A subsystem is like when you narrow down the view into just a couple of people in a family. So those themes are kept alive in the assessment, and then I bring them all back for a feedback review so it's a very collaborative appointment whereby I will share with them everything I've heard, how I've interpreted it. If there's a kind of tentative formulation, they'll hear about that. And that gives them the absolute right to tell me if I got something wrong, if I misheard something, if I've interpreted something the wrong way. And we kind of almost develop the report together. And then the report will be sent off to case manager, who works their magic and fights for my involvement. So that's the assessment phase. I'd say that's about a month. And that's purposely done as well. So if you meet somebody at the first day of the month, 30 days later, they might have different views, different thoughts about the situation.
It's making me think a lot of ecological systems theory, where you're building that kind of layered onion of different layers of the system. And it feels as though that's what you're doing in your assessment, because when you're speaking with the professionals around the family, you're not just getting their views, you're also understanding how they fit into the system, aren't you?
Yeah.
So that then you can kind of conceptualize the whole system and then offer your recommendations and support with that.
I'd say that's spot on. And most of the time, it'd be interesting what you think about this. If someone came and started to ask you some questions about, how would you frame how you're helping the family? And if they were here now, what would they tell me that you're working on? What would they say you're bringing, which they really appreciate? What would maybe, if they were here, what would they say that maybe they don't appreciate about your work? So I'm really getting the system to reflect on the therapeutic relationship. And it's so different, isn't it? If you're a physio, it's very hands-on, maybe much more tactile, and there's a kind of a different boundaries created there than if you're maybe a psychologist and you're kind of doing a bit more of a deep dive introspectively to somebody and neurologically as well. But I just gather all that information, I put it in a report, and people seem to appreciate that kind of like almost meta perspective on the professional system that's trying to merge with a family system.
Another question. I can see this spiraling, Dave, by the way, into lots of different questions, but
it's great. Fine.
About how the problem is defined. And I noticed you mentioned there, like, is that part of the curiosity of a family therapist of like what the actual referral point is? Because you mentioned like the index event, like it seems sensible in brain injury to note the index event because that's where life changed significantly for this system. But could you almost, without revealing anything confidential, talk about the type of referral problems that come up consistently, or how you even approach? Are you curious about how even the problem is defined?
Yeah, it's such a varied, wide-ranging presentations that people phone me about. So a case manager might just ask, can we just chat this through? What do you think? And it varies so much. So it's probably helpful for yourselves and listeners to imagine that the constellation of a family, and it does depend on how they define themselves, but it could be that it's the parent system that has been identified needs support because there's been a birth injury, for example, and they are trying to manage a child that's, deemed to have disabilities, and there are able-bodied siblings in the family, and balancing parenting of several of those needs all at once is actually now impacting on the parents and how their sense of their competence and confidence, and they're at an absolute loss and despair, and they're arguing, or they are losing connection between themselves. So that could be an absolutely one kind of type of a referral. Another referral may be older adults whose relationship, and they've got maybe children, biological children or children between them who are adult children themselves and doing their own thing, but the couple themselves have been affected by the ABI or TBI or whatever's happened, and they're drifting apart, and separation is likely to then actually, if you've got an adult child in the family who's a dad or a mum, and we've got children, we've got grandparents, and then almost generationally, there's been huge impacts here. So I suppose defining the problem for me, I help the system define the problem as well. It could be just really interesting to me that somebody would say, this spouse is almost getting in the way of psychology because they want to know what's going on, or they take up too much of my time. It's kind of like, so that's problematic, is it, for a psychologist that this spouse is taking up too much of your time? Maybe there's a resource there. Maybe they need more time with you. They need to understand what you're doing a little bit more. I could just help tweak that in the system. And then I would absolutely, part of my assessment would be, what do you as a family feel is needed? What outcomes would you like? And how do you see me being help with that? And they probably do need help and support figuring that out. So it's a bit of an analysis really of where the problems are. But I tell you something, and tell me what you think of this. I think a lot of families say, yes, we're arguing, or yes, we're not communicating as well as we would like to anymore. But I've noticed all this in the MDT. I'm not sure. I don't get on with my deputy, or we're not sure. We're not communicated with anymore about this, that, and the other. It's changed since the settlement. We don't feel valued anymore. So those things really affect how families, rehabilitation, or how families see their identity as well. So all of that comes into play, I would say.
Yeah, it's so interesting, and it got me thinking about how often, I think particularly in brain injury, the problem is almost always put on the lap of the person with the injury, because it seems most obvious. Like, they've gone through the change, they're the problem. I don't think that's the language that people would use, but it's, I think, what you feel in the system. And it's more about how the index event has changed how people relate and communicate. That I think is interesting, as you were talking there about relationships with things like deputies, with these professionals that never existed in someone's life before.
Yeah.
It's just a whirlwind of new relationships and ways of communicating and shifts, isn't it? And what I got from hearing about your initial assessment is it's about really shining a light on that as much as you can early on. And almost that forms part of the intervention, is a good look at what's going on.
Yeah, precisely that. And I suppose I could give an example confidentially in which I kind of said, this probably is not family therapy, but I could support the system. So it was a mother and son relationship. So we'd call that, it's kind of like a dyad, we'd say in old family therapy terms. So you can't do any kind of work around, you wouldn't see them as a couple. So you design your family therapy treatment as if, is this a parent and child? So the child, it was an adult child. So they had the accident when they were about 14, and I met them at about the age of 20, something like that. So it moved from a child parent into an adult child parent relationship, and they lived separately, but the mother would almost live with the son as well. So she'd spend so much time with the son. And the MDT wondered, these are legitimate questions. They're not wrong for wondering this, but there's questions about how much can we expect the son to become independent and autonomous with a bit of hidden brain injury, kind of one of them where out in the community kind of maybe wouldn't be able to tell so much because this is a hidden disability almost, but huge kind of executive functioning difficulties. And what they believed was a mother who was almost impacting on the son so much that she was limiting his ability to become independent and autonomous. But when I did the assessment, what the family described is almost generationally. It was so common for anyone, mother, daughter, mother, son, etc., to live in each other's pockets. And actually, independence and autonomy meant something different to this family than it did to the MDT. So my recommendations was almost like, let's do a watchful wait here. Let's imagine for 6 to 12 months, you don't try and separate mother and son anymore. You don't try to almost with using it like, it was almost like the MDT were trying to be the authoritative figure and the parent here and tell the mum what to do and what not to do. All that happened, and we talk about feedback loops in family therapy, all that happened is they got stronger because these figures were coming in telling them what to be, what to do. So in that way, so with this assessment, it was something that I said, I just don't think I could do anything in 6 to 12 months with this family because they don't want me to. But actually, I can see your dilemmas as a team. I can see you kind of like need to see what the son was like, managing a budget on their own, going out shopping on their own. Can they get their own friendship group? So how about I offer something in a consultative manner or method here to you? Now, the team did not go for that, but I just wonder if it was a good illustration for you where actually there's a there's a not wanting to intervene unnecessarily or too quick, and a respect. Yeah, maybe it is a respect for where families are, and that families are very different. Something I do with teams is think about how you kind of moved into independence yourselves, how you moved from living at home, if indeed you did, with this, was it a nuclear family, was it a blended family, how you moved from being independent into being an autonomous adult yourself. And we all would have done that differently. I felt for me, going to university was probably a really helpful way of doing that. And I think it is for many people. And lots of my kind of close friends had a real kind of almost like traumatic move into independence as well. So it's so different.
You were saying there, Dave, about people not being ready to engage. One of the questions that I've had burning in the back of my mind is, how do you as a family therapist work with the family where some members of the family are engaged and motivated to engage and other members of that family are not? Because I imagine that would be a real challenge for you.
I adapt my style depending on the family. And I feel that I've been doing that for so long and I've had really good supervision that I feel pretty confident in going into a family, noticing which family members are less engaged and maybe aren't keen on me being there, and using a certain style that within the hour they are going, can you come back again next week? Because I think the trick there of family therapy, and this is where it's a good question, Patrick, because you want each individual family member when you leave to feel that you were there for them. I say it's a trick, and it's not. I'm very transparent about it as well. I'm here to figure things out for you, Mr. So-and-so or Mrs. So-and-so, and the client, and the brother, the sister, the granny, the granddad. So they all come in thinking that they may need to invest something in their time to come to my sessions, but they will get something out of it.
So what I'm hearing from that, Dave, is throughout this whole discussion, it's family therapy is one of those, like so many other things in rehabilitation, it isn't a one-size-fits-all. It can't be an off-the-shelf package of support for a family and an individual. It's really built in a bespoke way around the person, their family, and their specific needs. And part of that is timing.
Yeah, absolutely. And I suppose it's a psychotherapy, really, family therapy. The proper title is a systemic psychotherapy. That's what it is. And it's therapeutic in nature. So part of my assessment is is this family able to engage right now in something that could be quite painful? Do we just need to focus on something else right now? And I can help the team focus on these other aspects at the minute. Do I need to offer something that's a bit more individually based? So I could imagine, say, after an assessment, what I might do is offer a mother 3 sessions, and I can do this alongside anybody else from the MDT. 3 sessions where we might just need to prepare for her to take a listening position to her son or her daughter or her husband, who may say things she is really finds quite painful, and she's defensive about that, or she can't hear anything critical because she's so busy trying to function where her child has this disability or brain injury, which is so difficult. So, there's ways around some of these things, but I think it's respecting where the family is and timing is something that I have to consider in my assessments.
Yeah, we asked Elizabeth Nightingale this when she was talking about neurologic music therapy, as if there are particular techniques that you use quite commonly. So, if we think of a psychotherapy like cognitive behavioral therapy, there's things like Socratic questioning. Are there particular tools in family therapy that you would use that might, elicit a response or encourage people to reflect on things? Anything that you go to or that you could share with listeners?
Yeah, I think it's such a good question again. So people may be familiar with the circular question, what a circular question is. And if you don't, I guess that is asking a certain style of question that would almost request family member A comment on the emotional experience of family member B. And that can be quite difficult, quite difficult to elicit that information, or quite difficult for family member A to really embed themselves in the experience of somebody else. When that's successful, it goes really well, because then you are asking family members to really understand the experience of other people, or try and guess the experience of other people. Now, you're not trying to get any truth, so that circular question would then lead on to another question, where you'd maybe turn to the other family member and say, is there something that you heard your brother or your sister or your mum or dad say that you want to comment on? Okay, so now you're getting a little bit of a circular process in which family member A and B or C or D are commenting on how they do things through your style of questioning. I think if you were to hear a family therapy session, it would just sound like a conversation, really. You wouldn't be certain, kind of, what's this guy doing? He's just chatting with this family, really. Is he doing anything? But you would hear, if you were aware of them, you would hear things like reflective questions, circular questions, triadic questions. You'd hear lots of pauses in which you are waiting for somebody to fill that space almost. It's not for me as a clinician to impose the next question or the next comment or where we're going to go next. So there's lots of silences that you might notice, and there's lots of work within those silences as well.
I think it's fascinating that you're almost a mechanic that's there to diagnose whatever problem there is going on. You've got your toolbox, and you're going to use that to elicit responses out of the various moving parts within the system to find a repair, to find a solution. And any particular problem in any particular system is going to be a different one to solve, isn't it?
One of you used the word reverse mentoring in your first or second podcast, and I liked that. So I've kind of used that a little bit more since I've heard it. And so the bit in my toolbox that I might use is in our next session, Patrick and Ben, as the clients, I may say to you, do you remember that moment when you got into that repeated pattern about pulling weight? And I didn't really try and find a solution with you two. I tried to explore it in different ways. Thinking back now, when you look back on now, what did you make of me doing that? And I'd pause. What I'm getting into there is our relationship as somebody who's coming in thinking and hoping they can help, and people being on the receiving end of that help. And the reverse mentoring bit is you're then shaping me as the clinician. So I came up with an idea of how I wanted to help you two in that moment. Did it land? Was it helpful to do it that way? I feel it was helpful as a clinician because I've got these assumptions and ideas that you need to go quite deep into what's causing. The symptom is the bicker, what's underneath. But you as the clinicians on the kind of receive or collaboratively doing this with you as clinicians, tell me what you thought of the way I handled that situation. So the toolbox bit is kind of like sharing this between us three, and then the iterative process and the reflective process is, well, next time, what do we need to do that's a bit different? And that's where the dialogue is.
And that shifts the power dynamic as well, doesn't it? Because it makes the people that you're working with feel as though they're not just the person that's being supported, but actually they're contributing something really valuable to you. Aside from the work that you're doing with them.
Yeah.
We're going to have to wrap up shortly, but it brings me on to two questions.
Yeah.
The first question is, what is the role of the therapeutic relationship within your work? How important is that role? And secondly, at what point and in what circumstances do you think case managers should be thinking about involving a family therapist with their clients? And what do we need to be thinking about? Because this is striking me as an area which is possibly underexplored by case managers. We need to be thinking about it more. At what point should we be considering involving a family therapist?
Yeah, thanks, Patrick. And that's what I'm hopefully here to do, is try and get some clarity on that and build the awareness of family therapy is out there. So the first question, so is a therapeutic relationship, the importance of that? It just has to be number one. If it's not number one, it's number two, surely. And it's the therapeutic relationship or therapeutic alliance with everybody in the family as well. And also with the team. The team need to, it's the word trust is coming to me, but I don't think I've got a particularly great definition of trust either. So I think everybody knows in spirit what that means. They trust me with their information. They trust me to be able to tell their story. They trust that I will, the certain promises I can give, that I will, communicate with them. If they ask me to do something, 99% of the time I'll do it. And if I've forgotten to do it, I'll let them know. So I'm building trust with all members of the family and the MDT right from the start, right until the end as well. It's so important, Patrick.
Just before you move on to the next part of the question, what you've made me think of there when it comes to trust is, part of trust is, I suppose, an element of psychological safety.
Yeah.
And being confident that when you're talking to somebody, they're engaging with you authentically, and that you in good faith, and that they're going to help to find a solution to whatever problem is going on, without judgment and without any kind of oppression.
So that's where I think the listening first comes into it as well. This is, so I was told about your podcast. I thought the title is brilliant. I do supervision, and often I'm thinking about how are you listening to this family? Listening is not passive. Listening is quite an active therapeutic tool, if we call it a tool as well. It encourages dialogue. And I think it's so in family work, we think about what's a monologue. So as an expert, as a specialist, we can get into monologues quite easily, and we've got to encourage the reflective element of dialogue, and we do that within families as well. So if dad is talking, I want to ensure that people have an opportunity to comment on dad, and dad has an opportunity to listen. So that's dialogue and listening first. So important in therapy.
Brilliant.
So there's no the other question. Ben, were you going to say something then? Sorry.
Yeah, sorry, I'm gonna hijack your question, Patrick, just with one that fits with that is, and this might be a whole other episode, but if you could cover this briefly, Dave, is for people with brain injury, they really struggle with some of the concepts we're talking about, which is introspection, metacognitive ability, reflection, holding things in mind, whether that's because of memory or executive functioning. How much do you need to adapt this, or do you work with other professionals to make this available and accessible to people with neurological injury?
Yeah, both. So anybody who's listening who's worked with me will can absolutely testify that my work is only successful because it's a successful MDT and family are engaged. So I need the MDT, I need the psychologist, neuropsychologist, speech and language therapist, OT. I need to be part of that system and work together with them. I guess I notice I am also adapting my work. So using kind of more like visual aids, visual prompts, trying to simplify ideas. So whereas I may say, we're working on conflict resolution as an idea, what it may say on the sheet, which I will bring and show and remind people who maybe have memory issues, that we are trying to reduce how often you argue, for example, something like that, and use of emails in between appointments. So I encourage particularly couples to sit down and read my email that I send maybe a week after the appointment, and they sit together and talk it through again. So it's another level of reflection. And also kind of, it's a bit of a tension, isn't it? Do you help a client who's got aphasia find the word, or do you kind of lead them a little bit, or do you stop and wait? So I go on what I'm helped by the MDT to do, but importantly what the client wants me to do. Certain clients get frustrated if somebody finds a word for them, and other ones go, oh, it's okay, help me find the word, please. So a lot of adaptation. Yeah. But I would also say one of my assumptions is that I think people with brain injuries, in my experience, often feel progress before they are aware of the progress as well. So they are in a slightly more regulated state. They can't always tell me whether there's less arguments with their spouse or not, but there's a feeling that things are okay between them and their spouse.
At what point should we be considering introducing family therapy, and in what circumstances do we need to factor that into our thinking?
Well, I would say there's probably on a spectrum between support and therapy, and the support I can just tell by how you talk and your your knowledge so far and your experience, and you too, Ben, that you will be giving family support. Absolutely, you'll probably be inviting them in, hearing their story, giving them some space to kind of talk and understand what's happening. So I'd see that in the category of support. And for some families, that might be enough, knowing they can contact Patrick when there's an issue, that you're available, or you'll schedule in a phone call with them, or somebody wants to join your session, Ben, just to understand a little bit more, do some psychoeducation. That's support, and that might be enough for some families, and they'll probably tell you it's enough. I think that the aspects to look out for is all the amazing facts that came to you so quickly earlier, Patrick, about which of the families are kind of saying, I'm in a real bad place here. Somebody said to me only yesterday or the day before, I didn't realise rock bottom had a basement as well. So they've been such at those depths of despair. And so we should be asking the MDT to listen out for care of burnout, high levels of care of burden, low mood, anxiety, distress. They just feel hassled. You'll feel it when you go around. I think we need people to be in touch with them, so we can be aware if people are really struggling as well. Someone like, I suppose you both, actually, I was going to say Ben, but you too, Patrick, if the client is saying as well, I'm worried about my husband, my wife, my child, if they're saying actually they really struggle with knowing how to be with me, they're not understanding me enough, that tells you maybe that needs something a bit more dynamic, a bit more couple based, or I can't parent him with him anymore, he shouts at the kids too much. That can come into some family therapy, because that could be about parenting. And in that situation, I'd also bring in granny and granddad and see if they can support the system. So it's all of those kind of red flags, if you want to call them red flags, that you could look out for.
Yeah, I've loved this conversation, and it's prompted so many other questions about adapting therapy, about the type of problems, about the type of techniques. We just simply don't have time to cover it, sadly, Dave. What we're trying to do is to keep a thread throughout the episodes and ask the person what rehab and recovery means to them. And that might mean personally, it might mean professionally, or both. So to you, Dave, as Dave and also as a family therapist, what does rehab and recovery mean to you?
That's good. You throw me with the whole, what does it mean to me? Maybe I need to reflect a little bit personally. I think professionally, this is difficult to answer, because I see rehabilitation as a journey. Some of the other guests have talked about, is there ever an end point to rehabilitation? So I guess, without doubt, for me, the lens I see this rehabilitation, it's a journey, and it's a journey that carries the family along with it as well. And I suppose that my sense of rehabilitation is almost like what conversations are evolving that involve the client and the nearest and dearest to that to the client as well. I can do a nod to kind of how are people in the MDT talking and relating, focusing purely on the family here now. Is the rehabilitation, is the journey that they're on encouraging different conversations between the family members? And are these conversations creating even newer conversations? And are we seeing difference in how they're communicating with each other? Are what they're talking about more about the love, support, connection, tightness? That's, for me, there's less about physical rehabilitation. It's almost relational rehabilitation.
Yeah, I love that. And I think for me, I've gotten so much from this conversation. If anything, it's just prompted lots of other space to think and read and check stuff out, really. And maybe that's a good question to ask is, how do people find out more about your work, Dave? Or is there anything you could recommend that listeners might read that gives them a bit more meat on the bones?
Do you know what? There was some people doing really good work out there with families. You mentioned Mark Holloway, the book that he's got, Family Experience of Brain Injury, that's called. Shout out to somebody, Freddie Byrne, who's a psychologist, got some systemic training down South Coast, I think, around there of the UK. Anchor Point are doing some really good work thinking about the family's experience of brain injury. I'm just, one person in all of this. I work out in the Northwest, of course. So if you want to know more, you can go on the AFT website. So that's the Association of Family Therapy. And they've got some leaflets that you might want to hand out to families. If you want to actually look for a family therapist, there is the UKCP. So I think that's the United Kingdom Council of Psychotherapists. And you can do little drop downs for who you're trying to find that will have people working in your local area. Can I do a shout out to the Newbie Psychological Services website? I'm on there. There's other clinicians on there.
Dave, it's been an absolute pleasure speaking with you today, and thank you so much for explaining to us about family therapy and opening our minds a little bit more to it. I'll certainly be approaching working with families in a slightly different way now as a result of this. So thank you very much.
I think you give me the opportunity to almost create an opportunity for families across the UK. I know, your listenership's kind of growing as well. So I really hope people think family therapy, and get in there and try and get families additional therapeutic support. So that'd be great if this is one of the outcomes from today. Thank you so much. I've enjoyed it.
Well, that was a great conversation, wasn't it, Patrick? I think getting Dave to reflect on family therapy and thinking more about how we sort of define a family within that system. I guess it's probably better to refer to it as systemic therapy sometimes, isn't it? 'Cause it's more about who's around a person. But yeah, a lot of take homes from that for me.
Absolutely, and I'm really surprised actually about how many parallels there are with family therapy and the work that I was initially trained to do in social work. They're very, very closely aligned. However, I'm ashamed to say that I've never used a family therapist in any of my case management cases, but following on from that conversation with Dave, I will absolutely be considering that in the future, because it's clear that there's such a huge value in bringing the people around our clients into the fold and giving them a space, because ultimately the better they are, the more able they are to be the best version of themselves for our clients, to help them in their recovery.
Yeah, definitely. And I guess even if it isn't, I think Dave alluded to this, even if it's not that they're providing direct therapy as a family therapist, I think to help a team understand at a systems level what might be going on around the person, in itself, just having that understanding as an MDT might be really helpful.
Absolutely. So thanks once again to Dave for joining us, and thank you to you, our listeners, for joining and being part of this important conversation. If you enjoyed today's episode, please like, follow and share the podcast wherever you get your podcasts. It helps us reach more people and grow our community. You can connect with us on LinkedIn at Listening First Podcast for updates, discussions and more. We'd also love to hear from you, so please do feel free to reach out and drop us an email or a direct message if you have any suggestions or comments or questions. Stay tuned for our next episode, which will be coming out very shortly, focused on safeguarding, but we'll leave that one there for now. Thanks again for joining us, and see you next time.